Hi, everyone. I'm Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation, and today I'm very excited to have Dr. Daniel Geynisman here with us. He's with the Department of Hematology and Oncology at the Fox Chase Cancer Center. He's a medical oncologist who specializes in genitourinary cancers. Doctor, thank you so much for joining us today.
Great. Thanks, Scott. Good to be here. Can you hear me? Okay. I hope
Yes,
everybody
sir.
can. Great. So I am a genitourinary medical oncologist. So I treat prostate cancer, kidney cancer, bladder cancer, testicular cancers, and a few other rare ones. And we have about an hour. And what I thought I'd do is, give maybe a 20 to 30-minute talk, which kind of goes over some big picture questions in kidney cancer, at least advanced kidney cancer. You can feel free to interrupt if you'd like. I think we can make this informal. And then at the end, we'll have time to chat. So what I'll do is I will share my screen.
Yes, and if anybody, we have a Q&A session scheduled for the end, so if anyone has questions throughout the presentation, feel free to type them into the chat box. We want to make sure that all your questions get answered before we end today.
Yep, absolutely.
Without further ado, go ahead and take us away, Doctor.
Okay, good. So you can see the title is Advanced Renal Cell Carcinoma, Frontline Therapy, How Do I Choose the Right Combination? This is a talk that I gave for the Judy Nicholson Foundation for the Patient Symposium just a couple of months ago. And so we'll go through this and then we can chat. So this is some of my disclosures. And here are at least my key questions for kidney cancer for frontline therapy. Number one, does everyone need treatment for advanced renal cell carcinoma? So aRCC is advanced renal cell carcinoma. Number two, for first-line advanced renal cell carcinoma, should we be using IO, so ipilimumab and nivolumab, pure immunotherapy, or a combination of a TKI and IO, and we have many options there. And then sort of a new question that has come up, which is what to do if one recurs after receiving adjuvant immunotherapy, right, which is now an option with pembrolizumab. So this is my sort of big picture 30,000-foot view map of advanced renal cell carcinoma. And so if you're diagnosed with this, right, we have to think about some of the patient factors, comorbidities, performance status. We have to think about the disease factors, things like histology. Is this clear cell kidney cancer? Is this non-clear cell kidney cancer? Is this associated with a VHL mutation or not? And then where is it located? Is it in the lungs? Is it in the pancreas? Is it in the liver? Is it in the bone? Is there disease in the kidney alone, etc.? And then what are our drug options? And this varies country to country. In the United States, thankfully, we have a lot of options, but this sometimes changes based on your insurance. Then you think about, all right, if I have advanced renal cell carcinoma, do I need a metastasectomy or ablative therapy? Can I go on active surveillance? And if I haven't had a nephrectomy yet, do I need one? In other words, do I need a cytoreductive nephrectomy? Something that used to be a very clear standard of care, something that we did all the time, but that has really evolved over the last 5 years or so with new data showing that a cytoreductive nephrectomy may actually not improve overall survival at all with our modern therapies. And then once you've thought about all that and you said, you know what, I do need systemic therapy, the first question that we need to ask ourselves is, what IMDC risk group am I in? Am I favorable risk, intermediate, or poor? Because treatment options vary there. For favorable risk, it's typically an IO-TKI combination or a clinical trial. For intermediate and poor risk, it's IO-TKI or IO-IO, or of course, a clinical trial. And then typically the paradigm, of course, is that whatever treatment you've received, you continue on that treatment as long as it's helping you, as long as you're tolerating it. And then at some point in the future, should you need it, you go on to second line and beyond. So that's the big picture. I mentioned the IMDC criteria, and I just want to make sure we're all on the same page about what that is. It was initially published in 2009, and it's been validated and revalidated many times since then in various data sets, but it really uses 6 factors. It looks at your hemoglobin at the time of your initial diagnosis of metastatic disease, your calcium level, your neutrophil count, your platelet count, your Karnofsky performance status, and then how long has it been since your original diagnosis of kidney cancer to the point now that you need systemic treatment. And it's very similar to the slightly older Memorial Sloan Kettering Cancer Center, or sometimes called the Mozart criteria, but with some modifications. And you can see here in the Kaplan-Meier curves, if you have 0 of these factors, in other words, imagine you've had a nephrectomy for a localized disease 10 years ago, and now you were in a car accident and you went to the emergency room as a result, and someone did a CAT scan of your chest to make sure you don't have any fractures, and they find 1 or 2 spots in your lungs, and these spots are biopsied and they're found to be kidney cancer, but you otherwise feel great, and your hemoglobin is normal, and your calcium is normal, and your neutrophils and platelets, everything is great. It's just sort of an incidental finding. You have 0 risk factors, you're in the favorable risk group, and you can see the overall survival is excellent, was excellent back in 2009, and I would argue even better today. And then if you have 1 or 2 risk factors, you are in the intermediate group, that's the yellow line, and then 3 or more poor risk patients. And you can see that poor risk patients still at that time of the publication did not do that well. Unfortunately, the median overall survival was still less than a year. Again, that curve has really shifted up, thankfully, with modern therapy, but these criteria are still prognostic, and we still use them for clinical trials and for decision making. So I mentioned active surveillance in my overall map, and I think it can be counterintuitive a lot of times, and I think can actually cause a lot of anxiety when somebody would recommend to have active surveillance, no treatment for advanced or metastatic kidney cancer. But here's some data showing that you can do this, and you can do this safely. So in the left, you see actually a clinical trial that we were part of at Fox Chase Cancer Center, along with a few other centers, showing that if you properly select patients for active surveillance, you can actually stay on it for an average of about 15 months. And some patients, as you can see in the swimmer plot, actually can stay on active surveillance for years with very slow growing metastatic kidney cancer. Obviously, if you're on active surveillance, you're avoiding all toxicity, all possible side effects of treatment. And so that's an advantage. You can see from another more recent publication that actually in the community, in sort of day-to-day practice out there, about 30% of people start active surveillance. So this is not a rare thing to see, and everybody's heard about it, and people are actually practicing this. And then the third panel on the right is not active surveillance, it is treatment, but it's actually localized treatment with SBRT, so focused radiation. And this was probably the news publication showing that if people have oligometastatic kidney cancer, so not too many spots of disease, and they're able to be all treated with radiation, you can actually have a fairly long period of time before you need any other treatment. The median progression-free survival was 22.7 months. Again, there's lots of patient selection here. There's lots of factors involved. You really have to individualize this. But the point is, not everybody with advanced kidney cancer needs treatment. And I've already mentioned this, but this is a timeline I like to put up, showing just the progress that we've seen in kidney cancer. So you can see all the way to the left, 1992, high-dose interleukin-2 approved by the FDA, and it was really the only treatment for many years. It is barely used anymore, extremely rarely, because in around 2005, the TKI era came about, And so you had the approval of sorafenib and sunitinib. And then you had the mTOR inhibitors, so that's your temsirolimus and everolimus. And you had more modern TKIs, pazopanib, axitinib, and then around 2015, you have sort of a next generation of drugs, and that's the immune checkpoint inhibitors. So here you have nivolumab approved for second line or beyond. You have some newer TKIs, of course, such as cabozantinib. And then you have this IO TKI combinations, right? Pembro, lenvatinib Pembro, axitinib avelumab, cabo Nivo approved. You had the pure immunotherapy, the Ipi-Nivo in 2018, and then even more recently you have tivozanib. And I put in belzutifan, of course, approved for right now VHL only disease, but soon to be for all renal cell carcinoma. So tremendous amount of progress, as we can see, which is obviously benefiting our patients a lot, which is wonderful. And this is another way to demonstrate that we're having a lot of progress. This is the response rate for frontline therapy in advanced kidney cancer. And you can see, for example, that if you're using sunitinib or pazopanib here on the left, which we were using as frontline therapy just a few years ago, the response rate was about 25 to 30%. And if you now look to the right with modern day IO TKI combination, depending on the trial, depending on the population, it's somewhere between, let's say, 60 to 70% response rate. So you've had basically a doubling of the response rate in just about, I would say, 10 to 15 years, okay? So then if you look at the NCCN guidelines, this was in 2010. Okay, so you have metastatic disease, stage 4, predominant clear cell histology. And it is important to note that this discussion is really focusing on clear cell patients. That's the 75% or 80% of patients with metastatic kidney cancer. In 2010, people recommended a clinical trial or sunitinib or temsirolimus for poor risk disease, which is a drug we basically do not use anymore. Bevacizumab interferon, pazopanib, high dose IL-2, as we mentioned, sorafenib. Okay, that was 2010. And if we look at today, you can see again a lot of progress. So we can first of all see that the patients are separated by the IMDC criteria we mentioned into favorable or poor and intermediate group. And then for favorable risk patients, category 1 recommendations is some sort of an IO TKI combination, dealer's choice. And then for poor and intermediate risk patients, it's those same combinations or Ipi-Nivo. And then you have a lot of these other recommended regimens that are there for particular situations or for particular reasons. So a lot more options and different options than we had in 2010. And I would argue that's a lot of change in a relatively short amount of time. So we're not going to spend much time on this, but the mechanism of action of all these drugs is somewhat different. The pills, the tyrosine kinase inhibitors, really work on this vascular endothelial growth factor receptors on the VEGF axis, blocking these pathways, preventing tumor growth by blocking blood vessel formation. They also block other pathways such as c-Met and AXL, for example, with cabozantinib. You have immunotherapy drugs here, such as nivolumab and pembrolizumab, of course, blocking this PD-1, PD-L1 axis. You have the CTLA-4 target with ipilimumab. You have the mTOR inhibitor axis with everolimus and temsirolimus. And then maybe one of the newest ones, this drug belzutifan that I mentioned, which is approved for VHL disease and will be approved for all clear cell RCC, also works on this VEGF axis, but works on it upfront by targeting hypoxia-inducible factor. So a lot of different drugs, somewhat different mechanisms of actions, but they're all came out of rational design, figuring out what the pathway is that stimulates kidney cancer, and then trying to interfere there. So again, I just want to point this out. This is where we were until really 2018. Okay, so just 4 or 5 years ago, frontline therapy was either pazopanib or sunitinib. the two TKIs. And you can see they were very, very similar in regards to their clinical efficacy. So the progression-free survival was around 9 months. You can see that on the left with the overlapping curves. And overall survival was virtually on top of each other, about 29, 30 months for median overall survival. Okay. And so then the first really change for this frontline therapy came in with Checkmate 214, which was a large phase 3 trial, as many of you know, looking at ipilimumab and nivolumab versus sunitinib. Sunitinib was given on its regular schedule, which was 4 weeks on, 2 weeks off, and then Ipi/Nivo was given with 4 doses of ipilimumab and nivolumab up front, and then ipilimumab goes away, and you continue with nivolumab. At that point, it was given at a dose of 3 milligrams per kilogram. That has changed now with flat dosing. And this is the latest update. This is at 60 months, so 5 years now follow-up. And you can see in terms of overall survival, the median overall survival was finally reached, and it was 55.7 months. Median overall survival for the whole population, which included favorable, intermediate, and poor risk patients. So 55.7 months versus what I just showed you, which was right here, around 30 months for pazopanib or sunitinib. Okay, so not perfect, but definitely progress. And importantly, if you look to the right, the progression-free survival, this is the part that people really are excited about, and this is the part people really are trying to improve upon, which is this plateau right here, where you see about a third of patients not really progressing at all on this treatment, not needing further therapy. That's the goal, okay, to sort of have a nice deep response that is sustained. You can see here the overall response rate was about 39–40%, and importantly, about a 12% complete response rate, okay, meaning no radiographic evidence of disease. This is where you hear people using the word cure. Can we cure kidney cancer? And at times we can. It's not common. It's not typically what we say our expectation is or our goal is, because I think that's somewhat unfair, but it is absolutely possible, and we certainly are always hopeful for that. And this is just for the intermediate and poor risk patients. So this is taking out the favorable risk patient, because this was the population of interest. This was where the primary analysis really was geared towards. And you can see here that the median overall survival is 47 months. So a little bit lower than for the whole population, because we've taken out the favorable risk patients whose biology is favorable and who just by definition do better. And the progression-free survival though here is still, you can see 31% plateaued, okay? So even if you have intermediate and poor risk disease, you still have that 30% chance of really having great response and plateauing with that response, not needing further therapy. About the same response rate and complete response rate in this group as well, okay? This is the favorable risk patients, so there are not that many. There was about 120 in each arm. And what you can see here is that the overall survival is about the same. It's right here on the left, 74 versus 68 months median overall survival. The response rate certainly is higher for a TKI here than Ipi/Nivo, but the complete response rate actually is higher for Ipi/Nivo. And so there's some debate in the field about this. Favorable risk patients are really dependent on this VEGF pathway. They respond oftentimes really well to TKIs. That's why you see the higher response rate for sunitinib. And the drug Ipi/Nivo, the combination, is really not approved for favorable risk patients. However, you can see that favorable risk patients can have a really good response rate as well. They can have a really good response rate as well. And the overall survival seems to be similar than if you start with a TKI. And there's certainly some proponents out there of using immunotherapy in favorable risk patients and one in their clinical trials, hopefully, that will be underway to see if this is possible. But right now, In favorable risk patients, we typically are not using Ipi/Nivo outside of a clinical trial. So 9.6%, about 10% of patients who got Ipi/Nivo achieved a complete response and did not subsequently progress or need other therapy, okay? So this is a very nice number, sort of clear statistic with long-term follow-up that we can talk to our patients about when we start this therapy. What are our expectations? What can we hope for? And the other thing that I think is important to mention is that this therapy can be toxic. You can develop immune-related adverse events. We've all heard about that. The itises, right? You can develop dermatitis, inflammation of your skin, pneumonitis, inflammation of your lungs, hepatitis, right? Inflammation of the liver. Pick an organ and it can get inflamed with immunotherapy. And if that happens to a serious degree, you have to stop the treatment. And one very common, very important question is, well, gosh, if I stop my treatment, does that mean that the response that I've achieved is going to go away? I'm not going to do as well. And the actually answer is no. And if you look at Ipi/Nivo, people who had the drugs who discontinued due to treatment-related adverse events, that's the top line in the dark, do just as well or better than the whole population. If you look at overall survival here, landmark overall survival, for example, at 42 months, 66% alive versus 56%. And that is consistent with what we've seen time and time again, which is people who actually develop a side effect from immunotherapy tend to actually have a better response and do better. It's a marker, it's a surrogate marker actually for being sensitive to immunotherapy. Even if you stop that immunotherapy, even if you treat those patients with steroids, that response does not seem to be abrogated. So that's an important finding, I think. So let's switch gears. That was pure immunotherapy, and that was the first modern therapy approved for metastatic RCC. And then came the second sort of modern type of therapy, which is a combination of immunotherapy and a tyrosine kinase inhibitor. So this was the first trial looking at this. This was KEYNOTE 426, and patients were randomized to pembrolizumab now plus axitinib versus sunitinib. Okay, so sunitinib again was given in a standard fashion. Pembrolizumab was given at 200 milligrams every 3 weeks, and axitinib 5 milligrams twice a day, with a dual primary endpoint of overall survival and progression-free survival. And so this has some latest data from KEYNOTE 426 with 43 months median follow-up and 36 months minimum follow-up. So all the patients had to have been followed up for at least 3 years. And you can see here the landmark overall survival at 36 months, 63% for Pembro/Axi, 54% for sunitinib. And you can see the median overall survival now is 45 months for Pembro/Axi, 40 for sunitinib. It's certainly statistically and clinically meaningful hazard ratio. And here's the progression-free survival. You can see 15.7 months for Pembro/Axi and 11 for sunitinib. Again, clear benefit to the IO-TKI combination versus the TKI alone. And importantly, and this is what differentiates IO-TKI versus Ipi/Nivo versus pure IO-IO, it's the response rate. If you see here, the response rate for sunitinib, the overall response rate was about 40%, which is actually quite high. Yeah, I would say typically it's around 30 to 35%, 3.5% complete response. If you look now at the IO-TKI combination, it is 60% with a 10% complete response. So you have almost a doubling of that overall response rate. Remember, for Ipi/Nivo, the response rate was about 39 to 40%. So you get about a 20% bump in the response rate when you use IO-TKI. So that means much less progressive disease, primary progressive disease. And that is a big, big fork in the road, I think, for clinicians and for patients when making that initial decision about what should I use for frontline treatment. Okay, you're gonna get a higher response rate with an IO-TKI on average than you do with Ipi/Nivo. And that sort of makes sense because you're picking a drug from each class, right? You're picking a drug from each category. If you look at the subgroups, so again, favorable risk versus intermediate and poor risk, you can see a couple of important parts. Number one, for overall survival, look at this. The hazard ratio crosses 1. There's no significant benefit here of IO-TKI versus TKI alone. It's very hard to show an overall survival benefit in a frontline trial for favorable risk patients because of how well they do, how many other subsequent lines of therapy are available. Intermediate and poor risk, though, clearly benefit for IO-TKI. And you can see similar for progression-free survival here, although very close to being significant for favorable risk patients. And you can see the response rate also. Look at this, look at for favorable risk patients. Sunitinib alone, 50.4. Okay, remember, normally it's around 30%, but it's almost 70% for Pembro aRCC. So really high response rate, which is great. Intermediate and poor risk, 56.5 versus 34.9 for sunitinib. And I don't want to minimize other IO-TKI combinations. I'm not going to go into the specifics just because of time, but it's important to note that there are other 2 commonly used level 1 evidence IO-TKI combinations approved based on phase 3 trials, and one is lenvatinib and pembrolizumab, and one is cabozantinib with nivolumab. Okay, there are similar trials to pembrolizumab axitinib. There are some slight differences, and we'll sort of go over a table that has them all next to each other. But these are the other 2 combinations that on the NCCN guidelines are category 1 recommendations. Both were positive trials versus sunitinib. And so here is that table. And here you see the 4 combinations: Ipi/Nivo, axitinib pembrolizumab, cabo-nivo, and lenvatinib pembrolizumab. You can see the median overall survival in this line. Okay, so 55.7 months versus 38.4, for example, for Ipi/Nivo. You can say, well, gosh, this looks different than KEYNOTE 426. This number looks higher. It looks higher than Checkmate 9ER, right? Clear it hasn't been reached yet. This is Len-Pembro. Remember, we have to be careful. I'm in no way saying we should compare across trials because every population is different. And actually, you can see that by looking down and looking at what proportion of patients were favorable risk, intermediate, and poor risk, right? So you can go from a trial like CLEAR, where only 9% of patients, for example, were poor risk, and you can go all the way up to Checkmate 9ER, where almost 20% of patients were poor risk. Well, that's going to make a very big difference, right? You can imagine for your, for example, median overall survival or your response rate for the entire population. So you have to look at each trial by itself, but it's understandable to compare. We all do that, and sometimes that is helpful as you make treatment decisions for a specific patient. You have the landmark survival at 12 months, 24 months. You have the response rates, of course, here. Okay, and I think the important part again to point out is the response rate for IO-TKI combinations, whether it's 60 or 56 or 71, are really high and definitely higher than Ipi/Nivo. And if you said, well, what's the highest one? Which drug combination got you the highest response rate? It is lenvatinib pembrolizumab, 71%. Complete rate, 17.2%. And then also interestingly is the prior nephrectomy number, because remember I mentioned that it used to be most patients did get a nephrectomy even when diagnosed with metastatic disease. That trend has dropped down when we saw that actually doing a cytoreductive nephrectomy may not improve survival. And so you can see here with trials like Checkmate 9ER and CLEAR, there are fewer patients who've had a prior nephrectomy. And then here you have the rate of primary progressive disease. Okay, that means that that very first scan on trial shows that there's actually progression by RECIST. Okay, greater than 20%, 20% or greater increase in the target lesions. And it goes anywhere from only 5.4% for CLEAR all the way up to 17.6% for Checkmate 214. Again, very important numbers when I think you're sitting in front of a patient and trying to make a decision about what the right treatment option for them is. So you also have to think about toxicity, of course. So when we're talking about immunotherapy, and I already mentioned it, there's the itises, okay? Pruritus, pneumonitis, myocarditis, adrenal crisis, all sort of itises. When you think about the VEGF TKIs, there's the high blood pressure, the taste changes, the stomatitis, the dyspepsia, the low blood counts, right? Hand, foot, skin toxicity. But then there's also overlap. There are side effects that can happen from either, and it makes it challenging to figure out which one is actually happening and which drug is causing it, right? Rash can happen from either TKIs or immunotherapy. Diarrhea can happen from either. Hepatitis can happen from either. Hypothyroidism can happen from either. And change in mental status can actually happen from either, depending on the drug, although with different etiology. So it's an important thing we think about. And for example, when patients are getting immunotherapy and TKI together and they have a side effect, we kind of have an algorithm that we try to follow. We stop typically the drugs, we wait for the TKI to wash out, which typically the half-life is relatively short, especially with a drug like axitinib. And then if the side effect persists, we sort of start to think, gosh, this is likely immunotherapy related. So what you haven't seen is any head-to-head data for Ipi/Nivo, pure immunotherapy, versus any IO-TKI. You've seen Ipi/Nivo versus Sutent, and then you've seen IO-TKIs versus Sutent. And we can all agree that Sutent is no longer the standard of care for frontline therapy. There's no question about it. Pazopanib is not a standard of care for frontline therapy. But what you haven't seen is Ipi/Nivo versus any IO-TKI combination. And that's because none of those trials have been done or initiated for that matter. And so again, how do you choose? We looked actually at a large sample of patients from the Flatiron database, which is a large database that collects information on many practices throughout the United States to try to ask this question. And we had about 960 patients who were treated with Ipi/Nivo, about 550 who were treated with Pembro, and that's because that's the first combination that was approved, so that was what was available. And this is what we showed. If you look at progression-free survival for the full population, there really isn't a statistically significant difference, it seems like, or I should say clinically significant difference. If you look at intermediate poor, definitely no difference. But if you look at favorable risk patients right here, clearly IO-TKI is superior to IO-IO. Okay, so 25.5 months versus 6.9 months, very consistent with what we talked about before, given the biology of favorable risk disease and given how it's dependent on the VEGF pathway. If you look at overall survival, similarly in the full cohort, no statistically significant difference between the two combinations. In the intermediate or poor, no difference. But if you look at the favorable risk patients, it seems to be benefited from IO-TKI. Okay, so we can take this and say, gosh, you know what? If you look at everybody, whether you choose Ipi/Nivo or whether you choose IO-TKI, seems to be very similar. Overall survival, very similar, overlapping curve. You can make that decision with the patient. And if you're thinking about if you're a favorable risk patient, well, gosh, if you're really looking for that response, TKIs are important. So how do you choose? These are the 4 trials, once again, and their pluses and minuses potentially for each. So for Checkmate 214, right, there's the Ipi/Nivo, potential for durable response, and you don't have to take a TKI. You don't have to deal potentially with that hypertension, that hand-foot syndrome, that stomatitis, the taking of the pills every day, etc. But the lowest response rate, and there's a chance of long-term toxicity from the Ipi/Nivo, a long-term, for example, itis, okay? Whether it be adrenal insufficiency or diabetes, right? It's a higher possibility than with a PD-1 checkpoint inhibitor alone. KEYNOTE 4 to 6, that's using axitinib and Pembro. Well, axitinib comes in 1 milligram tablets, and sometimes it's easier to titrate when you have 1 milligram tablets. It's something that folks are familiar with. Drug has been around for a long time. But if you look at quality of life data, there actually wasn't a clear quality of life benefit in KEYNOTE 4 to 6 for the IO-TKI combination. If you look at Checkmate 9ER, right, that's the cabozantinib nivolumab combination, the quality of life actually favored the combination. It was positive for quality of life. There's always the question of patients who have bony disease, whether cabozantinib is a good drug for that. But then again, you have the TKI toxicity, as any TKI can have its toxicity. And then in clear, that's the lenvatinib pembrolizumab, you have the best overall response rate, progression-free survival of any IO-TKI combination. You have to, though, think about that the dose was quite high. Lenvatinib was given at 20 milligrams, and that's oftentimes not possible in real practice. And then again, you have the TKI toxicity. So pluses and minuses in each one. And so when I'm thinking about how to choose first-line treatment, at least in the intermediate and poor risk group, and you have this kind of seesaw of a IO versus IO-TKI combinations, you can go through this in your head with your patient. Well, if you do IO, it's easier to choose subsequent therapy. It's going to be a TKI because you haven't had one. You could have an off-treatment period. If you have a nice response, or if you have an immune-related adverse event, you can stop all the immunotherapy and just observe someone, and sometimes they do really well. Remember, that's the tail in the curve. Cure, the complete response. That's what we are always hopeful for, and it's possible with this combination. It's possible with this combination as well, but possible without a TKI, and it has the longest term follow-up. If you think about PD-1 and a TKI, PD-L1 and TKI, well, it's addressing both pathways. You can continue on one drug only, so you can stop one drug and continue the other if you need to. It clearly has a higher overall response rate than Ipi/Nivo and fewer immune-related adverse events. And so you really got to talk this through and think about patient preferences, think about the clinical scenario. So if you're a purist, you may say everybody should get IO, or everybody should get IO-TKI. I think that's probably not the way to go. I think you have to be practical, and you say it depends. It depends on your performance status. It depends on your preference. It depends on your burden of disease. If I'm seeing someone who has, unfortunately, a lot of metastatic disease, liver disease, bone disease, brain disease, this is not somebody that I'm going to give Ipi/Nivo to typically. I'm looking for that very high response rate. I need to make sure we get great control of the disease because I'm worried that we're not going to be able to get to second-line therapy if this patient progresses. What if you have autoimmune disease already, underlying autoimmune disease? Well, sometimes it's a contraindication totally for any immunotherapy, but oftentimes you would be willing to try some, but probably not Ipi/Nivo. So I can say I just started somebody on an IO-TKI combination yesterday who has a sort of seronegative rheumatoid arthritis. I am giving him a PD-1 inhibitor, but I certainly would not give him Ipi/Nivo. And then there's specific comorbidities. There are some patients for whom steroids would be really challenging to handle. They have some brittle diabetes. Again, I would stay away from Ipi/Nivo. There are some patients who have completely uncontrolled hypertension, for example, or severe cardiovascular disease. Well, TKIs will be really tough, and maybe Ipi/Nivo is the right way. So I think the key here is not what is right necessarily, but what is wrong, right? And clearly what's wrong is single agent TKI for most patients. That is wrong. That's under treatment. We're beyond that. So in favorable risk patients, it's a little bit less obvious. The biology is often indolent. TKI alone here, perhaps only here, is an option for some patients, although really the guidelines and the general consensus is IO-TKI is still better. But there are some patients who you can discuss and probably safely, certainly safely treat with TKI alone. Local therapy, remember, and observation, active surveillance are appropriate for these patients, okay? IO alone is an option for those strongly motivated or as part of a clinical trial, which would be highly preferable, okay? I want to remind folks that if you have sarcomatoid renal cell carcinoma, which can happen with any sort of pathologic subtype, but if you have sarcomatoid renal cell carcinoma, immunotherapy is critical. Immunotherapy is absolutely critical, and actually sarcomatoid renal cell carcinoma responds really well to immunotherapy. You can see here the overall response rate from various trials involving immunotherapy. It responds very poorly to TKI alone. And then I just want to mention briefly, because it was presented at ESMO, people were waiting for that, which is the Cosmic 313 trial, which is an important trial, and an important one because it's really the first modern trial where the comparator arm, the baseline, the standard of care, was actually Ipi/Nivo, okay, which is an appropriate modern therapy. It was not sunitinib. So it was Ipi/Nivo compared to Ipi/Nivo/Cabo triplet in intermediate and poor risk patients, okay? And this was some of the data. You can see that on the left, progression-free survival did favor the triplet, Cabo, Ipi/Nivo, not reached versus 11.3 months for the Ipi/Nivo arm. But if you look, the response rate of the triplet was 43%, right? Which is lower, certainly, than what we would expect with an IO-TKI combination. The complete response rate was really low, underwhelming, although there's a caveat here, which is that 35% of patients had a primary tumor in place. The kidney was in place because people are not doing the cytoreductive nephrectomy. There was a really high grade 3 or 4 treatment-related adverse events, so 73% patients had that. 12% had to actually discontinue all the drugs because of side effects. Almost 60% had to get high-dose steroids, and we have no overall survival data yet. So I think this is certainly not a standard of care. It is not approved, I think it was an important trial, but it's something to build on. I'm not convinced that this is going to really enter the armamentarium, certainly not anytime soon. So what about post-adjuvant IO? This is a switch a little bit in gear. Remember, pembrolizumab is now approved as an immunotherapy as adjuvant therapy in kidney cancer. We have sunitinib, which is really not used. We have a number of trials that were negative trials presented at ESMO, actually 3 of them, but the one that has been positive was pembrolizumab. And so what happens if you're someone who's got adjuvant immunotherapy, pembrolizumab, and then at some point down the road, unfortunately, has had a recurrence? Well, the answer is no one really knows. There are ongoing frontline trials that are allowing adjuvant immunotherapy if it's been greater than 6 months or a year after you've stopped it. There are really no active trials studying this yet. And I'll just say that practically, what most people would say is that if significant time has elapsed since you've had adjuvant immunotherapy, it's reasonable to try again. But if it's been a really short interval, probably not. And I think that's the best that we can answer right now. It's really an unknown area. So I just want to point out that there are certainly trials that are ongoing. You can see there are other triplets that are being evaluated. For example, belzutifan with pembrolizumab and lenvatinib, or a CTLA-4 inhibitor with pembrolizumab and lenvatinib versus pembrolizumab. So that's another sort of ongoing trial. You can think about trials like this, which is a cooperative group trial where you try to induce a response with Ipi/Nivo, and then based on what kind of a response you have, you randomize patients to either continual immunotherapy or a TKI like cabozantinib. And then really the holy grail is to be able to use genomic data to figure out really what kind of tumor you have. Is it an immunologically responsive tumor? Is it a tumor that needs TKIs? Is it a tumor that needs belzutifan? Is it a tumor that needs something else? And then using that data, really do individualized therapy, right? Personalized therapy, as we all are hoping for that disease. And then I'll just finish and say, beyond first-line therapy, there are many options, and there are drugs such as cabozantinib and lenvatinib, everolimus, and nivolumab, which was actually, again, initially approved for second and third line. And then there are newer drugs, belzutifan, which is coming up and is going to be approved, tivozanib, which has been approved, and even the combination of lenvatinib and pembrolizumab, which has some really encouraging data for second and third line treatment, okay? So if we go back to our clinical questions in advanced renal cell carcinoma, does everyone need treatment for it? And my answer is no. active surveillance can be safely done. For first-line advanced kidney cancer, should we use IO-IO or IO-TKI? I hope I've convinced you that you can do either, depending on the situation. And then what do you do if you recur after adjuvant immunotherapy? The answer is we don't know, and we have to take the practical scenario and make a decision based on that. So with that, I'll sort of say a huge thank to all the patients and all the families I think that we treat, that enroll in clinical trials, that have really made this progress possible. None of these trials obviously would have happened without patients and their families willing to take a leap of faith. And it's really an honor to take care of them. And you know, my whole team here at Fox Chase and the Judy Nicholson Foundation for putting this together. So I'll stop sharing, and maybe we can have some time for Q&A.
Yes, sir. Thank you so much. We did have a question from Daria. She says, hi, how many patients who achieved a complete response to IPI and Nivo continued to save a complete response from your real practice, and how long?
So from Checkmate 2 and 4, it's almost everybody, not everybody, but almost everybody. In Checkmate 214. If the question is from the real world data, that I don't know. I don't have that information. If you're asking about the Flatiron paper, it's a good question. I don't think we looked at that. But practically, to answer that, folks who achieve a complete response tend to do really, really well. Most are able to sustain that complete response in daily practice.
And Karen asks, what can you tell us about those with non-clear cell, specifically advanced papillary?
Yeah, I think that's a great question. It's a whole separate talk. Non-clear cell RCC has very different pathways. It unfortunately oftentimes not as responsive as clear cell to any therapy. You know, the standard of care right now, I would say, if there is any, still probably remains a drug like cabozantinib, okay, which was evaluated in the SWOG trial. We know IO-TKI combinations actually can do really well, whether it's cabo-nivo or lenvatinib pembrolizumab in non-clear cell. So papillary, for example, which is the most common type of non-clear cell RCC. So I think there just needs to be a lot more work in that field. But practically, again, if you're asking, what people do is they try the same things as clear cell. People basically take the data from clear cell RCC and they extrapolate to non-clear cell. And some patients are lucky and are able to get a good response. Unfortunately, more than not are not. And so that's how I would answer that question. So IO-TKI is certainly used very often in non-clear cell RCC.
Thank you, doctor. Marianne asks, would IPI-Nivo to start make sense for a person, for a good performance person with rhabdoid foci?
Yeah, so I think the answer is yes. And I think the answer is yes because folks with sarcomatoid changes do really well with immunotherapy. And I'll take the rhabdoid that you mentioned in that same bucket. What I will say is the person with rhabdoid disease probably is not going to do well with a TKI. I don't think the TKI is going to do much for them. I think immunotherapy is key. So I actually, that would be my preference, for somebody who has those kind of changes. All else being equal, given that, again, it's a reasonable therapy for other reasons. Like that person doesn't have some sort of a terrible, autoimmune condition.
All right. One other question. If anyone has any other questions, feel free to unmute yourself or type into the chat. We'll be wrapping up here soon. Is it true that only patients with no other major health problems should try combination therapy?
No, that is not true at all. We treat many patients. In fact, I would say the majority of our patients who have, lots of other medical comorbidities. It's, We live here in the United States, and people have heart disease and diabetes, have had other cancers, have high blood pressure, and we're able to manage that. I mean, you have a multidisciplinary team for this, so not true at all. Not true. Most of the time, you can manage the comorbidities.
All right, everyone. Well, thank you so much for your time, Dr. Geynisman. I think
Sure.
this was a great talk. If anyone missed any portion of this talk, it will be posted on our YouTube and our website shortly. So please keep posted for that. Our very own Jayla Barnes is doing a talk that'll be our next event in December. You can find that on our website. It's a pull up a chair and let's talk. It's one of our patient support series videos. So you're more than welcome to join us. Marianne says, Dr. Geynisman, great presentations. Thanks. So I'd like to thank everyone for coming today, and especially you, Doctor. Everyone have a great day.
Thanks. Always happy to chat. And if anybody has any questions, they can always shoot me an email.
Perfect. Thank you, sir. Have a good day.
Thank you. Bye-bye. Bye-bye.